All right. Well, hello, everyone. Thank you for joining our Washington HIMSS chapter. Today, we'll be covering a topic that's unique to pediatrics, and that's in regards to challenges that they're facing when it comes to health IT. We have some great speakers lined up, and we have a great facilitator, so we're really excited to be able to present this topic to you today. Just as a reminder, if you are joining us through Zoom, please make sure that you're on mute. If you're joining us through your phone, make sure you're muted as well. This session will be recorded and will be available on our YouTube channel, and we'll share that out shortly after the recording. All right, so our agenda today is I'll give you a quick introduction to our HIMSS chapter, share with you a little bit information about who we are and what we do. And if you're interested in becoming a member or becoming more involved, we're always looking for volunteers. We're also always looking for speakers and sponsors. We'll go through our panelist presentations. So each one of them will have about 10 minutes to present some of their top health IT challenges that they're facing in their organization. Then we'll have also during that time, Dr. Sue Kressly will kind of quiz them on some of their topics and kind of bring to light some important facts that they've discovered throughout their challenges. Then we'll have a live Q&A, so you guys will have a chance to post your questions and comments in the chat. And then we'll go over some upcoming events for our chapter. So just a brief overview about HIMSS if you're new to the organization or interested in becoming a volunteer or a member. HIMSS stands for Healthcare Information and Management Systems Society, and we're a nonprofit global advisor. And our goal is to really be a place where folks can come that are interested in healthcare IT, where they can get information about education or resources or a way to network with others that might be facing the same healthcare IT challenges. So I put our link at the bottom and also put it in our chat a bit later. The vision for HIMSS and for our chapter is really to realize the full health potential of every human anywhere. And our mission is to reform the global health ecosystem through the power of information and technology. So a little bit more concrete examples of what HIMSS does and what kind of things are engaged in is if you go to HIMSS.org, on the left side, for example, you'll see some of the initiatives that they're supporting. For example, nursing informatics, or there's a healthcare record association. So information around all those types of areas are being supported through HIMSS. And then if your organization are looking for solutions, we always have thought leaders that will help to guide and consult where needed. So again, we want to be that hub of resources and hub of networking for everyone. We are a nonprofit organization, so we rely on our sponsors. Currently, our elite sponsor is SailPoint, and in the past, we've had the following sponsors. So we just wanted to acknowledge them and thank them for their contributions. Otherwise, we would not be able to proceed with these events. So let's talk a little bit about our speakers today. Dr. Sue Kressly, she's a pediatric health IT expert. She is a board-certified pediatrician and clinical informaticist who has over 30 years of clinical experience in pediatric practice and almost 2 decades of business experience as the founding partner of innovative Kressly Pediatrics, and over 15 years in pediatric health IT, championing the pediatric voice at the health IT table. Then we have Dr. Sarah Stewart. She's also a pediatrician and current clinical informatics fellow at Seattle Children's Hospital and UW Medicine here in Seattle. She completed her residency in pediatrics at Lucile Packard Children's Hospital at Stanford University. She has previous digital health and consumer medical device experience as a consultant, and she has previously worked in Internet of Things, such as glucose and oximetry sensors, strategy and operations at early age telemedicine startup. Then we have Dr. Matthew Fradkin, who comes to us from Providence, and he's a provider informaticist Also a pediatrician, he is currently spearheading efforts to redesign the pediatric care model for the system to align with value-based and digital-forward care. Prior to his work at Providence, he was a pediatric and clinical lead for Medumo, which is an automated SMS-based patient education and monitoring platform. And last but not least, we have Dr. Mark Lowe. He comes from Seattle Children's, and he is a pediatric emergency physician, a medical informatician, and medical director of telehealth and digital health. In addition to the emergent and urgent medical care of children, he is passionate about how technology can be used to influence and transform pediatric healthcare, especially for those with limited access and underserved populations. So you'll see throughout, and based on their bio, you'll see some of the challenges that they're facing currently in their organizations, which will be really interesting. Okay. So we have our first poll question, and we're just curious, do we have any, are you a pediatrician or do you have a pediatric clinical training? And let's see, you can, let me launch the poll. Let's see if I can relaunch it. Hold on. Nope, it won't let me. Yes, there you go. So you should get a little question that pops up, and you should be able to answer. In a few seconds. And if you don't have access to the poll for some reason, you can feel free to put that in the chat. It looks like so far 50-50, we have a split. A couple more seconds. All right, so I'll end the poll and I'll share the results. So it looks like 53%. Yes. Great. Okay. So Dr. Sue, I will let you take over.
Thanks so much. And thanks everybody for joining us tonight. And I wanted to take that poll because so often pediatricians are talking to our own little ecosystem with other pediatricians. And I'm thrilled to see that almost half of the audience is not pediatricians. So we are taking our conversation to a broader audience, and we encourage each of you to spread what you learn here to 10 other non-pediatricians so our message gets heard in a broader audience. So I don't have to remind the pediatricians of this, but the non-pediatricians, we have to remember that kids are not just small adults. We know in our medical training that their anatomy is different, their physiology different, their needs are different. They have unique activity patterns like crawling on the floor and banging their head, on the bottom of a counter. They keep growing and developing and have different needs and different capabilities at different times in their lives. We also know, and this becomes very apparent in health IT, their caregivers and family relationships are incredibly complex. For the tech people on the call, I think of that as a many-to-many relationship that there's no end to. They also have a reliance on adults for assistance, which changes over time as they grow and develop. And they are way more vulnerable to exploitation than the average adult. Next slide. So we have to remember that their pediatric health IT needs are also different. We have to figure out how do we get pediatric tools that support the needs through the whole trajectory of the pediatric life. For those of you who've been at this as long as I have, you may remember the initial EHRs only had ages in whole numbers. And clearly a 3-hour-old and a 1-year-old are not both, a 0 or an almost 1-year-old. We know that we have unique problems with patient identifiers. A lot of us have a nomenclature in the newborn nursery where the baby's name is baby, mom's last name, her first name, and a sex. I guarantee you that's not what they go home as. And about half of them will even change their last name. We also have the challenges of quadruplets or multiple births delivered within seconds of each other. And if your EHR only can do it in minutes, you may look like you have two kids that are exactly the same. And now we have interesting naming nomenclatures that vital birth records isn't the same in every state. I personally had a patient whose name was, that's supposed to be L, but they thought it would be cool and put the E's backward and make it threes. That is Dasha, spelled with a dash and an A. If you don't know who that last name is, that's actually Elon Musk's kid's name. So not sure how I would type that in our record, but it probably will have the same problem registering for school. So it's not just our tech. We know that vital signs and growth parameters are way different for kids than adults. And think about the accuracy of weight that's critical in the NICU down to, hundredths of a gram sometimes. And I actually was fortunate enough when EHRs were first coming on the horizon, speaking at to the first ONC in DC. And we were talking about, like, there's no place for head circumference. And he was like, oh yeah, you pediatricians are worried about head size. Like, I guess that matters. It's like, yeah, it matters. Next slide. So today our speakers are going to highlight some of our existing challenges, and the topics that we will discuss, and hopefully it'll get broader than this, are a lot of consent requirements, which are unique for kids over their life trajectory, privacy and confidentiality issues, especially around portals, transitioning health records from childhood through adolescence into adulthood. How do we get equitable access for all of our kids? Social drivers of health and pediatrics, and what does it mean for the electronic health record? Unique challenges with integrating pediatric patient-generated data. And then we're going to look at a little bit at the integration of third-party apps with a pediatric focus, and really where that's headed. Next slide. This is from the Robert Wood Johnson and adapted by the American Academy of Pediatrics. And I just want to pause here and remind people, when we talk about health equity, we're not talking about equality. If we give all of our patients the same tool, think about a way to log into a portal, you will only meet the needs of some of your patients. If you give everyone the same bike, if you happen to be shorter, or you happen to be differently abled, or you happen to not fit on that bike, it's of no use to you. If we're really going to get to equity and health equity, including in our IT, we have to make sure that every patient has the right tool that they can utilize to have the best outcomes. Next slide. So for those of you who've never been in Itasca, which is the home of the American Academy of Pediatrics, this is one of my favorite quotes on the wall. And I want to remind people who think they need a return on investment in 18 months, which is really what a lot of the payers and others are looking for. If we're going to build the foundation of a better life for all patients, we have to remember that kids, they're probably now a little less than 1/3, it's probably closer to 1/4 of our population, but they are all of our future. And if we do not build things from the ground up, the first 18 floors of the skyscraper, we are going to have problems in getting health equity and optimum outcomes for our society for years to come. Next slide. Okay, Sarah, take it away.
Great, thank you. So just as another introduction, my name is Sarah Stewart. I am a clinical informatics fellow, a second year at University of Washington in Seattle Children's, and work as an ambulatory pediatrician. Next slide, please. I am going to focus primarily on this complicated picture of adolescent patient portal access, and then review a special consideration of the cognitively impaired adolescent. So to share or not to share, this is the question I often get from adult providers. Why do we want so badly to provide patient information to our adolescent patients if it's so complicated? And I think the most important things to highlight are that giving this access really empowers our adolescents as they age from children to adults to become part of their own healthcare. It promotes the patient and family engagement with the healthcare system and their care team, and it complies with the 21st Century Cures Act, which is important. Next slide, please. So it seems like we've been grappling with this problem for years. As a resident, I heard people talking about this years ago. Why is it so complicated? And one of those reasons has to do with adolescent healthcare consent and how that fits into confidentiality. So for those of you that aren't pediatricians, I'm going to highlight some of this for you guys quickly here. So there are federal and state specific adolescent consent laws. Specifically in Washington state, you can see here the age of consent to certain care, from STI testing to mental health and substance abuse treatment. And then at the bottom, routine care, so non-emergency care like a well child visit, immunizations, etc., can't be consented to until that patient is 18, and prior to that their guardian must consent to. So the top 6 things there, the adolescent can consent to at a certain age or stage. The bottom 2, only the guardian can do that until they're 18. Next slide, please. So what does this mean? This means that for these first top 6 cases, this care is protected under state law and must be kept confidential from the parents or guardians unless the teen decides to disclose that information. Next slide. But for the routine care, the guardian has to consent, and thus this information can be shared freely with the guardian without any issues. Next slide. So while this is complicated and we don't have standards or consensus recommendations right now for exactly what to do when it comes to information sharing to our adolescents and their families, we do have consensus from adolescent experts, pediatricians, informaticians that we should be sharing this information with our adolescent patients, and the complexity really comes in how we do that. So how can we approach this? I'm going to highlight 3 different approaches on how you can use your EHR to set up accounts for families to access their adolescent health information. So option 1, you can just give access to the adolescent. They can access all their records. It's just them. Parents are removed from the situation. There are concerns when you do this that a parent might get into the adolescent's account because they want access to either the information or the care team, etc. So coercion concerns with that. Next option is a parent or guardian only account. This enables the guardian to continue to coordinate care, but it disempowers and undermines that teen if they don't get access to that information once they're able at that age where they can consent to that care. This is often the type of account that is set up for pediatric patients up until that teen year. So for, a 10-year-old, oftentimes we have proxy accounts set up for a parent or a guardian to have full access to their child's health information. Next option is option number 3, setting up accounts for both the parent and the teen. There's kind of 2 sub options to this. You can either give full access to the teen, including all of their confidential health information, and limit access to the guardian, so not including that confidential information. Or you can do limited access for both the adult and the teen. This gives us, This gives us ability to coordinate care from the parent standpoint and empowers the teen, hopefully also allowing to protect teen confidentiality and reduce the concerns about coercion. Next slide. So I wanted to highlight a really interesting study from 2021, kind of looking at how we're doing with this. These authors looked at 3,000 adolescent patient portal accounts and used a NLP algorithm to analyze 25,000 messages sent from these accounts. And as you can see, these were primarily patient accounts. So adolescents having their own accounts. The proxy registration rate was 0.3 to 10%. So basically, these were patients where they only had their own account, not a high percentage of parents or guardians also having a proxy account. And what they found from this study was that 3/4 of the time, one of those messages was flagged as being sent by a parent or a guardian. And what that means from a confidentiality standpoint is, as a pediatrician, I'm sending a message to my patient, assuming that the 16-year-old is the only one accessing this message. But it turns out in 3/4 of these cases, the parents probably have access to these messages and this information. And that's something that we struggle with, as we're responsible for keeping this care confidential, and us as people involved in the IT implementation of these systems have to really consider. Next slide, please. So the authors of this study took a guess, and an educated guess on why this was happening. Errors during sign up was a big one. Putting in the patient's parent information when you activate the account, so all of that goes to the parent and not to the patient. A misunderstanding of that there are different accounts and what they can do from the patient and adolescent standpoint. Adolescents, especially early on, right when they turn 13, maybe they don't want this account. They're not interested in this. Here, mom, dad, you take it. And not realizing that maybe when they're 16 or 17, they're going to actually want that privacy and that confidential access. And then the last is the risk of that surreptitious or coercive overtaking of the adolescent's account by a parent that wants additional information. So we recently went live with a new EHR at our health system, and we had to decide what we were going to do in terms of adolescent patient portal access. We went with option 3 here, creating accounts for both adolescents and their parents. We have unique logins. These are 2 separate accounts. Everyone has their own login. And we decided to do limited access for both. Both the adolescent and the parent have matching access, but it's only to information that we deemed as non-confidential. The reason being is that we wanted to decrease the risk that the parent knows there's something more that they could access by accessing the patient account. And also, if they did somehow get access in there, we didn't want to risk them seeing confidential test results, etc. Both accounts, importantly, have the ability to confidentially, without including the other account, message the care team. Next slide, please. So I wanted to just highlight some of the problems and why this is such a difficult problem and why we don't have all the answers. I think we're going to continue to have to iterate on this as we move forward and get feedback from our families and our clinicians. It's really difficult to see who's accessing that patient portal account at the end of the day. I don't know whose phone or whose email or whose computer desktop I'm actually sending that message to. I know who I'm intending to, but actually who opens that message, I'm not sure. Consent laws differ across the country. So I showed you Washington State. Those are very different from our colleagues across the country who have different ages for those different services. It's also really tough when you're setting up these kind of barriers of segmented data to make sure you're including all the confidential information. So a doxycycline prescription, yeah, we use that for acne, but we always also use that to treat an STI. And is that going to flag if a parent sees that and wonders why their patient is on that, their kid is on that medication? Another difficulty we run into is health information exchange, which we absolutely love and really benefit from as clinicians, can actually breach confidentiality if our neighboring system gets our information and then shares that through the patient portal to our patients when they're seen there. Overall, we have that lack of standardization. And lastly, insurance companies. As a pediatrician, we're very aware that insurance companies send those EOBs to the families, and they often list a lot of information on there, and that can risk confidential disclosures. Next slide, please. So in the future, we would love to be able to confirm easily who's accessing this information. We would love to standardize minor consent laws across the country, have a thoughtful list of what is considered confidential information versus not. I think having some best practices for these portal settings would be really helpful, not just locally in Washington State, so we're all on the same page, but across the country. And then I think we need to mandate some extensions of this confidentiality to our insurance providers too. And then lastly, I just wanted to highlight an interesting patient population here. We take care of complicated patients. For example, a teen with severe cognitive impairment, they see multiple subspecialists. They require a lot of complex coordination of care that their guardians are helping with. This patient, due to their severe cognitive impairment, is unable to consent to the type of confidential care that we were referring to earlier that a typical teen can consent to. but they really benefit from their parent being able to engage their whole medical team and have access to all of their information. So in this case, it doesn't make sense just to blanket statement, give that limited access. Maybe it doesn't even make sense to give that teen, depending on their level of cognitive impairment, access to their information. So our organization, we partnered with our ethics and our risk management team to create a robust workflow to figure out how we can serve these patients best, and provide full access to these guardians to help coordinate this care, while not infringing on any confidentiality issues for other teams across the system. So thanks so much. Those were the topics I was going to bring up. We now have another poll question and see how you guys are doing things at your systems. So do you allow adolescent patients access to their own health information? And if so, what type? Interesting. Okay. Yeah. See, we don't have standardization. Very interesting.
Yeah, that's terrific, Sarah. And I put in the chat, for those of you who don't know, there's been a couple years effort, started with a couple informaticists from the AAP to advance this conversation while we're talking about kids today. This also affects geriatrics and anybody else who has a proxy, including differently abled people, as Sarah pointed out, with the adolescent that she was saying. So thanks very much for that, Sarah. I'm sure there's going to be some interesting conversation and questions as we move forward. All right, who's next up? I think it's Matt.
Hello, everyone. Just want to thank y'all for inviting me, Washington chapter of HIMSS, for inviting me to briefly discuss and maybe complain a little bit about some current health IT challenges that we are currently butting our heads against here at Providence and Swedish. Again, I'm Matt Fradkin. I'm a pediatrician as well as a provider informaticist for Providence and Swedish medical groups. And I just want to take some time here to highlight some new avenues that we're using for investigating and investing in value-based care for our pediatric population. Next slide, please. So let's face it, most EMR is not built initially for pediatrics, just as Sue mentioned earlier, and I think everyone who's a pediatrician here knows very well. And oftentimes this lack of foresight when developing these foundation systems leads to the very fragmented and particularly non-continuous or contiguous nature of the EMR data collected over a patient's lifetime. And oftentimes pediatricians, especially one like myself at these larger health care organizations that are really designed to help provide care for a patient over their entire lives, the ability for us to find the data that we collect from the patients over their formative years tends to be lost in the shuffle as they continue to age and move on to adult specialists, or even from young patients to early adolescence to teenage years and college years. Or even more simply, for us, even one well visit to another, sometimes it's difficult to keep track and measure progress on developmental milestones. If you take our ability to track developmental milestones from visit to visit, it's quite awful when compared to lovely tools that some of our adult providers have when measuring and tracking response for treatments such as diabetes, high cholesterol, high blood pressure, etc. in our EMRs. Next slide, please. So how do we get our voices heard as pediatricians in a large healthcare group or system? How do we make enough noise so some of that informatics FTE gets sent over to some astute pediatricians to help solve these problems? Well, here at Providence and Swedish, one way that we're becoming more vocal from a pediatric standpoint, and more so trying to be a little bit more of a squeaky wheel here at Providence, is by making an overall healthcare expense argument for getting more interest and funding for pediatric side of our EMR and health IT. With the consolidation of healthcare and more of these birth to grave healthcare systems and the increase in EMR usage along an entire patient's lifespan, there's more and more evidence, especially the evidence coming up in the last 5 to 10 years, that addressing particular determinants of health in the pediatric years can provide for immense savings over a lifetime for the healthcare system. And for what it's worth, in our current system, money talks and gets the FTE in our value-based care world. So that's the angle that we're using in the pediatrics department to get our foot in the door and to get a little bit more leeway in terms of designing the EMR and making tweaks for it that will help yield to better outcomes. So our main focus is dedicating ourselves to showing that a pediatric-focused informatics agenda can reduce the per-patient lifetime cost to the system while providing better outcomes for the continuum of age and health. A pediatrics-first informatics provides immense value. Next slide. The time and the place where we have been and are still looking to collect the information that we think as pediatricians will help guide our patients and their families to better health and health decisions has been the well child visit historically. And boy, do we try to squeeze every possible question we can think of to address everything in that 15 to 30 minutes that we have with a family maybe once a year. I mean, this is a lot of letters to look at. It's alphabet soup. All the screeners that I've listed here, we have them in our system one way or another, have all been validated in sort of a better use me or you could miss something way. And at certain times for certain patients, these screeners do have a place. But again, from a value-based care lens, do these screeners actually touch on the points that we have started to see through our own and others' larger healthcare systems data repositories? Do these screeners really play a much larger role in cost and overall healthcare dollars? And I know I should not be talking about money when it comes to the health and lives of pediatric patients, but I do so because it grabs the ear of the C-suite that we're working with the added benefit of these data elements or milestones will also enhance the health and wellness of the child that we're seeing at the time. So I call it a win-win, if you ask me. So does this alphabet soup matter in terms of value-based care for the lifetime of a patient? For me, and for the data that we're collecting, the answer is all the above. Yes, no, and sort of, depending on what you're looking at and when. Next question. Or sorry, next slide. Oh yes, next question. So the poll that we have, as you can see here, have you guys used any of these screeners, especially for social determinants of health in clinic? Okay, so it looks like, oh, majority do some sort of custom set of questions, which is similar to what we do here at Providence in Swedish, sort of a mixed bag depending on the validity of the study and when we're sort of touching base with the families. Okay, next slide. So some research groups who are much smarter than I am have thought a lot about these questions as well. And by using lifetime healthcare data within a single healthcare system, groups such as the Robert Wood Johnson Foundation, UCLA Health, and more recently, the North Carolina Integrated Healthcare for Kids cooperative with Duke University, are really sort of leading the charge in terms of value-based care medical decisions early on in life for the pediatric population. They're really looking at which questions from these screeners or maybe new questions over a lifetime, at what age does a given intervention yield the highest return on investment, or I would rather say return on health. And it turns out only a few of the screening questions that we ask out of the dozen times a day that we ask these dozens of questions really make up the lion's share when we look back at overall cost savings or healthcare utilization over a patient's lifetime. Next slide. And these questions so far are sort of almost fit on your hand. The questions that we're looking at now are maternal depression at birth, vocabulary at age 2, kindergarten readiness at age 5, literacy at age 8, school connectedness at age 14, and high school graduation at age 18. I know, I was just as surprised as you guys when we were first going through this data from these other groups and even from our data set. I mean, where is the, can you get a Cheerio out of a clear cup question for all of our pediatricians out there? Again, I'm not saying that those other screeners are not good or not validated. I'm simply saying that these are the ones most associated with eventual or overall healthcare dollars spent in the lifetime continuum of the healthcare system that we're currently working in. Next slide. So obviously, just like with more pixels, you get more resolution and better picture. We need to be able to collect these new data points from all the areas that these data points are evaluated and addressed in a child's life to really get the full health, high fidelity picture. We do a good job at getting the clinical data from all those screeners we mentioned above, maybe even an okay job at getting information about home life with some of those screeners. But overall, we do, at least historically, we do a poor job at being able to collect data from all these educational sources. And with the questions that we were asking above or showing above, it was really majority education concerns. I mean, for us, for Providence, one of the largest healthcare systems in the country and the largest user of Epic in the country, we only just received the data points in the foundation system for IEP and 504 plans to be placed on the social determinants of health section of our patient chart within the last year. And getting those on board, that was also a mini battle in itself. And the difficulty in getting these sort of multi-location data sources in a kid's community to the pediatric office really is sort of our biggest health IT challenge that we're trying to face right now in terms of value-based care. Next slide. So the questions that we're having, that we're thinking over and really our challenges is all about the data. So how do we get this data? Where do we get the data from? And if we get it, is it reliable from the source that we're getting? Is it current? A kiddo may not be literate today, but give a couple weeks, maybe they are. How often do we need to query for this data? Should we even be getting this data? Is it sort of our job as pediatricians to be asking all these educational questions or prying to see how connected a child is or what they do in their off time in high school? Who is responsible for getting and verifying this data? And maybe more importantly, is the community or healthcare system where we practice even have the bandwidth and ability to address some of the shortcomings that we find when we ask for these particular questions that really are addressing our value-based care concerns. Next slide. So our work at Providence, again, has started with baby steps, like I previously said, providing new data elements in the EMR to track some of these things by even restructuring our social determinants of health section of the chart to now include IEP and 504 plans. And again, having them present as sort of trackable, always present things to see, be seen and see by all the providers sort of interacting with the child in the social determinants of health section, which is much more prominent than other parts of the chart. But we're looking to eventually develop, build, even and integrate a community-based approach to the EMR to get these data points. I mean, it does take a village, right? How do we get a patient's second grade teacher to let us know they can read? How do we get a child's baseball coach to let us know they're not showing up to practices? How does a guidance counselor let us know if the patient is on track to graduate? Right now, we're really looking towards the North Carolina integrated child care framework in that they're making efforts right now to start to coordinate and act on this information as well by including community partners in the child's chart. They actually, in the care team part of the chart, there's a shared action plan, and it will have a child's counselor in there. It'll have the school principal information. It'll have, if they're signed up for dance class or baseball or whatever, the coach's information is in there. So they're really trying to really hammer home the idea that this information is not just in the pediatric office, but we need to collect it from other sources in the community. Even so, that if there are concerns, there's now funding with this program for family navigators who will support the family for at least 1 year and conduct quarterly check-ins to address those concerns that we talked about before. And as providers, those providers of those pediatric patients have access to this patient's shared action plan, as well as reports with actionable data on patients in terms of kindergarten readiness, et cetera. And so by working towards a digital solution for this community-based value enhancing care, we hope to also benefit from this community-based approach to the EMR. But the concerns and technical hurdles are plentiful, as you can all imagine. So if anyone has any good ideas, I'd love to hear them. Don't hesitate to email me. But that's sort of where we are right now, just really trying to understand how do we get validated current data that we can act on to really help these kids both in the now, but also over their lifetimes. So thanks everyone for letting me share my information.
Thanks so much, Matthew. That's incredibly interesting. And I applaud whoever got over the HIPAA-FERPA divide that causes a lot of consternation between sharing health data and educational data, living in the same world to actually see the whole child. So great presentation, and I look forward to the conversation. Mark?
Great. Well, hi, everyone. Thanks for having me. I think it's been a really interesting talk so far, just with these different points of view. I'm going to talk about, continue to talk about some of the challenges that we have in health IT, really trying to draw the differences out in pediatrics. And so just a couple additional points to what you've heard already. Next slide, please. So really starting with consent. And this is a pretty hot topic, I would say, and really very clearly different when it comes to an adult consenting for their own health and in pediatrics, where we really have to seek permission from the right people. And you would be stunned at how many different permutations there are when it comes to who has the legal sort of ability to consent for their child. And so we have definitely different kinds of families. We have, if the patients, the pediatric patients in the foster system, we have to go down a different road, or if they're in the custody of law enforcement or whatnot, CPS, there's just a lot more intricacies in trying to find that consent. And it became very clear to us during pandemic when we had to seek some of these consent forms and get them signed virtually. I think it made it very challenging and really highlighted some of the differences in children. You can't just say, do you consent for care and you're a sort of responsible adult and you just sign the paper. We really had to kind of go the extra mile to find out who was responsible and really seeking permission. Kind of what Sarah was talking about, also just looking at portal and some of the challenges that she highlighted. We continue to deal with that and try to figure out what's the right age for allowing patients to take care and take ownership of their own data. One story or one thing that perhaps some of you on the call have dealt with is our recent SSB 5195 that went live in January. And this law, for those who are unaware, really required in Washington State emergency departments and inpatient sort of behavioral health or psychiatric units to dispense naloxone for those who are at higher risk. And it makes a ton of sense, I think, especially from an adult perspective, but I just want to flip it on the other side. And when you look at it from this pediatric perspective and how we try to integrate this with issues of consent, we have to, in our build and our IT build, we have to really consider who's going to be looking at that. Does that information go into the portal? Ideally, from an adult standpoint, you want everyone to know if you're at higher risk, you might need naloxone, but from a pediatric standpoint, do we have permission to do that and show that or put it in the portal, et cetera? So just some additional intricacies that arose. If there are any builders in the audience, if you are building an app or whatnot, I think trying to nail down the terms of consents or terms of use in the app, trying to figure out how you're collecting your data, where you're storing it. Those are common issues for adults as well, but for pediatrics has that additional layer where is that patient of age to be able to consent for that themselves or not. And again, I think Sarah brought up a really nice point about especially in a specialty shop where I work, chronologic age may be very different than developmental age. And so if someone is 20 years old chronologically, but developmentally at 10 years old, how does that affect things? And so you really need to be very cognizant of that when you're building and when you're trying to make your consent forms and mobile app sort of agreements. And then I just want to talk a little bit about authentication, because this is something, again, that is very much different in pediatrics. If I as an adult go into a clinic and I say, this is who I am, and I can show you my driver's license or my insurance card, and you just, yes, I am this person, and you can see the picture, we can just go ahead and do that healthcare visit. However, for children, for pediatric patients, we don't really know. If you go back and look at even in your in-person authentication methods, we don't really know if you are who you say you are. And I think, again, during pandemic, this became really, really apparent for us, because when it comes to sending a video visit link or a text message or whatnot, we're sending it into the ether, into the internet somewhere, and we're hoping that that person is indeed a guardian or parent of this patient. And, you know, when we're switching from all in-person to all virtual, as many of you did, I think we had a lot of robust debate on whether or not we should use portal or not portal, because as Sue was talking about in terms of health equity, I think if you have an additional layer of login, et cetera, it really is a little bit more painful than if you just sent the link directly, for example. And we use our vendor's portal as a way to authenticate. And that's a strategy that many IT shops have chosen, health IT shops have chosen. But I think it also, it's a limitation as well. So we're using it as an authentication tool, but it has its own downsides. And so you need to consider that, because, you know, maybe the portal is only in English, or difficult to get to an additional login, or needs two-factor authentication or whatever. And so it's just something else to consider that is even more pronounced in pediatrics, because you have to really trust that the person is bringing the child is really a person that's supposed to be. It's, on a side note, it's sort of why blockchain is a really attractive technology. If you can really nail down the authentication piece of it, I think it will really serve us well, especially in pediatrics. Next slide, please. And so kind of dovetailing what Sarah was talking about, confidentiality, really want to talk about pediatric privacy as well. And this is, again, very different than adults who are responsible for their own privacy and keeping their information private. I think as pediatricians and working in pediatric health IT, really need to go the extra mile to ensure that the pediatric patient has ability to seek privacy. And so this came up again during pandemic for us, where we were surprised to find that many of our adolescent patients were preferring to come in person versus doing everything virtual. And when we asked them why, it's because they just did not feel that they had a private space at home if we were trying to do a virtual visit. Someone's listening in. It's kind of back to the old days where people had phones, landlines, and someone else is on the line. You're not sure if your parent is listening, et cetera. So we're really surprised to see some of our patients prefer in person, because they could guarantee that that visit was private. And, you know, again, we're learning so many things from pandemic, but one of the things we lost was that many pediatricians will say, I'm just going to spend a couple minutes with your child. They say to the parent, I'm going to spend a couple minutes with your child, and just, if you don't mind just stepping outside, we're going to talk confidentially for a little bit. You know, in a virtual world, that's not really doable. You can put them back in the waiting room, maybe if the parent's on the call or whatnot, but it just is, you're not sure exactly what's going on in that patient's home when you're connecting virtually. We've had instances, and I'm sure many of you on the call have, but you know, surreptitiously, I think someone had mentioned before, but we're doing this virtual visit, but the whole visit's being recorded by someone else, or there's someone else beaming in that we didn't know about from a phone. And so just having privacy is really a very important thing. And the pediatric patient, they depend on the parent or guardian even more for that privacy. And so I think that's definitely one of the things that's been highlighted for us compared to adults, is that we need to try to, again, go the extra mile for pediatric patients and try to make sure that they have private areas. I threw up the question here just as a sort of hypothetical or question. Is just like, if the patient is really dependent on the parent for all these different things, are they really able to fully access their healthcare? Really, we have to be thoughtful of just the dependencies. And so developmentally, well, I'll just use an example. So say, I don't recommend this, but for many families, if the kid gets grounded, the device is taken away, for example, right? And I don't recommend that, but especially if that is a mobile phone or something that child is using to connect to their peers, et cetera. But for example, it's like, okay, you're grounded. I took away your phone. You needed that phone to access your healthcare appointment tomorrow. That's a sort of vulnerability, an additional vulnerability that pediatric patients have. And I think we need to really be cognizant of that in the pediatric health IT space. And then finally, we have a responsibility, I would say, in the pediatric world in terms of teaching these developmentally growing patients about privacy and taking control of their own health through technology and data. Adults, you don't have to worry about that as much. You just assume they're responsible. But developmentally, kids are very different. It's almost like movie ratings. Should I take my 5-year-old kid to watch Top Gun Maverick, right? It's PG-13. But I think we have to try to raise kids or show kids, guide kids in what's appropriate for them or not. And so another example of that during pandemic, through virtual physical exam, we made a choice not to have sort of sensitive areas of for physical examination, exposing oneself on camera, et cetera, because we didn't know what that would do to sort of the pediatric mindset as well. And so if you needed an exam that was more sensitive, we asked you to come in person. So some issues like that. And then certainly as they're engaging with chatbots and digital health apps and whatnot, we just really we recognize that we play a different role than adults, perhaps, for pediatric patients, where we have to guide them a little bit more in how they navigate this world. Next slide, please. All right, here's a poll. So what age do you think adolescents should have access to their own patient portal without parent or guardian supervision and access? If you have children of your own or adolescent-aged children, young adults, that may be particularly relevant.
They're slowly coming in. I have about 66% participated. Give it a few more seconds.
So again, just like the previous polls, it's very split. There's no hard and fast answer on this. And so I think continued discussion around this area is going to be really important for us going forward. So health equity, kind of tying in with what Sue was talking about earlier. And this has a lot of crossover with adult health IT. And so I think the main topic I just want to draw out is this additional vulnerability of pediatric patients in health IT, where they're dependent on a parent or guardian for certain aspects of that digital health access, and just really call out that additional vulnerability. I will say that when we launched virtual visits, one thing that became very apparent to us, and it's in the literature and it's been published on, and everyone has experienced it in some way, shape, or form in their different health systems, is that the digital divide became very apparent in terms of those with access to technology could continue their healthcare, those with not. If you're in a lockdown situation with pandemic restrictions, you could not access your healthcare. And so what we tried to do was, we certainly have not gotten this dialed in completely. We probably tried to tackle it from the equality standpoint, really more so than the equity standpoint, but just trying to make sure that we offered technology like devices for those who didn't have it. We got a couple community grants, some local business grants to be able to supply tablets for those who didn't have it, partnered with sort of local telecom to provide hotspots if they needed it, tried to really translate our videos on how to connect, et cetera, to multiple languages, trying to make it easier to access and get better health literacy around those areas. And it was hit or miss. And so the advantage, I guess, from pediatric standpoint for us during this time was that we could follow the public school system a little bit and how they rolled out their access to technology, et cetera, and try to learn from what they had done. And it really went beyond just even as Sue said, it goes beyond just having the right device or the right hotspot, the high-speed internet, whatnot, but it really goes into the full social determinants of health. You know, one thing we realized when we went virtual is that you can start seeing the background and get a better insight into that patient's home. And so we recognize that a lot of our recommendations for healthcare were not relevant or not feasible for those families, and we had to take that into account. So I think just really being cognizant of pediatrics, in addition to all the social determinants of health and other health equity issues, there is the vulnerability of population where if the patient is young, you have to address not just that patient, but sort of where that patient lives and what their food security is like, things like that. And so we have to really try to take care of that whole child. Next slide, please. And finally, for if there are any sort of builders or developers in the audience, just a quick word on design thinking. And as you try to build for your customer or your audience, you know, many of us are very into these patient journey maps or these journey maps. And just a reminder that for pediatrics, the journey map you design for the patients may be very different than the one that's needed for, say, for example, for the family or the guardian or the parents. And just keep that in mind when you are building and sort of mapping it all out, taking into account the patient's cognitive level or reading ability, et cetera. You know, we really had to, even in a whole process, going virtual, rethinking the whole process, we had to ask ourselves the questions, things like, you know, is a patient even really needed at this visit if the whole purpose of this visit is to do education to the family or the parent? Can we make it more convenient for the family if we do this after hours and the patient's already gone to sleep, for example? We had to address kind of trickier questions and privacy, legal, IT security don't love this, but you know, should we be recording some of these virtual visits? Because in some situations like a behavioral health and autism diagnosis, they need to run that tape back and make the diagnosis virtually through a recording. And so those are the kind of questions we need to be approaching when we're trying to design the best pediatric experience in our healthcare system. And then finally, just want to end on this is that in adults, we just trust that if you want to spend, you know, your entire day on the phone, that's your choice and you're responsible for that. But for the pediatric patients, we have some additional, I would say, constraints, or just we have some recommendations from AAP in terms of how long we really want these patients to be on the screen. If you're building an app and if you're a developer, you want it to be as sticky as possible. If you're on TikTok, you want to just you know, get them lost in all those videos and they spend hours on their phone. I think the latest stats I've seen is that something like teens are on average 9 hours on a screen a day. I think those who are less middle school, it's like 4 to 6 hours. AAP has recommendations that they don't have many hard and fast recommendations, but certainly in age 5+, maybe like an hour a day on weekdays, 3 hours on the weekends. And so I think as pediatricians, we're obligated a little bit to really consider those things and ethically consider, should we be trying to make apps and health IT experiences that are so sticky and really expose them to all that screen time. So I'll just end there, and I'm looking forward to a great conversation online. Oh, additional poll. when would you trust your children, if you have them, to engage with a digital health app on their own without supervision?
Wow, that's terrific. Again, lots of depends and nuance, and isn't that pediatrics? It's all nuanced. It depends on the kid, it depends on the family, it depends on the community. We have a lot of it depends, but thanks so much, Mark and Sarah and Matt, for those great presentations. And I'm going to take a couple of minutes to ask the panelists a few questions. In the meantime, you all are going to get to ask your own questions, so please start putting them in the chat. And I have to say, I'm really thrilled to see all the engagement. Glad you were all involved in the polling. And we should do something with that polling data, Joanna, at the end, because I think that it's representative, which is we raised more questions than we answered, which is typical when we have this conversation. So I'm going to toss this up for whoever wants to lean in here. I'm famous for saying that the first thing we should do when we're having conversation about pediatrics is to decide whose voice is missing around the table. And from your experience in your organizations in health IT, whose voice do you think is missing at the health IT table in your organization in order to advance health equity for all of our kids? Who wants to take that?
I can start it off. I think probably one of the most obvious answers are the kids, the patients. It's really hard to engage them at an organizational IT level in these conversations. And we're trying to do that, with our patient portal work. How do we survey our patients and our teens and ask them how they feel about the access they're getting, how they feel about the potential of their parents getting access to this information? And then, like you said, Sue, reaching those patients that we aren't reaching through these kinds of technologies, and how do we give them that same type of care that we're providing through, a patient portal where someone can message us. If you don't have a smartphone, if you don't have reliable internet access, we're probably missing out on some of the care that we can provide. So really being cognizant of that and going above and beyond to reach out to those families to figure out what we can do to bridge that gap, the equality versus equity image you brought up earlier.
That's terrific. Matt, Mark, you have anything to add?
I just second that, not only just patients, but families. And so I think most places are really trying to focus on family-centered care, patient-centered care. But I think at the health IT sort of project level, it'd be really nice to continue to have more voices from the end user, and really understand what their needs are. How feasible is this? We've definitely run into projects we've kicked off, health IT projects we've kicked off, and everyone's been really jazzed about the technology or whatnot, only to see it fall flat because it just wasn't feasible for so many families. And I think if we could bring more of that into our initial build and kickoffs and really understand what problem are we trying to solve for them, I think that would really save us. I mean, it's going to be a win-win for everybody because it'll save time and it'll be more effective. It'll be more feasible.
Yeah,
including those SDOH issues.
I think that we still, because we live inside the health system, we pretend that we're family centered, but sometimes have conversations without them. And even organizations which are trying to add more diversity and adult feedback with culture linguistic. But then you have to add the developmental stages of all the kids for us and abilities, and you have to add the difference of what's a family, right? Like even defining the differences in nuances of families is very complex. Matt, you got a closing thought about this?
Yeah, I mean, I'm in agreement, like the more patient and family input, the better. I think though, for coming from a larger healthcare organization that's not just focused on on pediatrics, it would be nice to have some more pediatricians on these groups to sort of get an idea of how things work with, especially for social determinants of health screening, like, how feasible it is to add these to the workflows with everything else we're supposed to be doing. And then also knowing what the pulse is of the community, that if we do request for these interventions based on things we're asking or based on data points that we're getting, that we have the resources to do so.
Great. I'm going to follow that up with one question for all of you, and then we're going to go to audience questions. So if I gave you $1 million, and it's not really enough, but $1 million to solve one problem in your organization, what pediatric problem would you prioritize solving, and how would you go about it?
I'll go first, mostly because it's very much on my mind and in front of me as a pediatric ER doc. But I would put all resources right now into trying to address the pediatric mental health crisis. Whether we can fix that with health IT, not so sure, but I think we are understandably sort of just reaping the consequences of kids not being in school and in contact with each other for the past couple of years, and it's a tremendous effect right now. So I would, whatever, if we could dump that money into different digital ways to address, or just even in-person ways to address that, that's where I would put all my chips. So,
well, that's fabulous, because I've multiple times said we can't scale ourselves out of this problem. And so we have to figure out how to deliver healthy mental health messaging to every patient. And I do think that there's probably some technology ways that we can do that, but I'm also worried that it worsens the health equity for those that have and those can't access it. But I hear you. And especially when you're talking about Matt's paradigm of building for a healthier tomorrow, there's an opportunity loss cost here. So if you don't get your $1 million, the health system's going to be paying for it for generations. And we know about what adverse childhood experiences does to our epigenetics and how it's going to be expressed in even more chronic diseases in these kids. They are clearly there's a lot of speculation that they are going to have a lower life expectancy than us, and that breaks my heart, that my grandkids may live shorter life than I do. Matt or Sarah, if you got $1 million.
Yeah, I mean, I'd reiterate what Mark would do. Just as a primary care pediatrician, that's a big chunk of our days now. But I would sort of add on, I'd use a lot of that money for building more community partnerships to get kids out and active and connected again as well. I think that would be best. We get a lot of return on health and return on investment with that.
I love that return on health. I'm going to use that. The payers I've gotten as chair of the payer advocacy committee at the Academy. I've stopped saying ROI, but ROI TY, which is return on investment this year. If it's not cost saving this year, they don't want to hear about it. So I love flipping the conversation to return on health. All right, Sarah, your $1 million.
Yeah, I think if I had $1 million, I'm similar to Mark. Mental health is a huge component of primary care, but just having the ability to facilitate patients accessing their care teams, like you said, but it's not a scalable problem. We can't just make more of us as pediatricians. We need to figure out another way that we can meet these needs. And maybe some of those are through, chat bots or, some sort of automated technology where we can get rid of some of the noise, administrative tasks, stuff like that, and then really focus in on the places where we can provide value as clinicians and make room for others who don't have the time to sit on hold. A parent who's working 2 jobs can't sit on hold for an hour to try to make an appointment. So reshuffling things that we can prioritize where we spend our time, making the most meaningful contributions.
I love that. Using technology where it adds value and leaving the human touch where it is most needed, and reducing burnout and our administrative burden along the way would be fabulous.
Yeah.
So thanks so much, guys. Joanna, I'm going to turn it over to you.
Sure. I'm just going to leave this slide up. What we do during our events is always collect feedback from our attendees to see if they found the event to be valuable and any possible topics you'd be interested in hearing about in upcoming events, in person or digital. So while we're doing our Q&A session, we have some questions queued up already. Feel free to scan that to access our survey form. I also posted it in the chat box, so you'll have access to the links. Okay, so our first question is from Sonia. What are the most important things that EHR vendors can be doing to address these challenges? More options for configuration, more guidance on best practices, etc. Feel free to unmute yourself, Sonia, if you wanted to elaborate more on your question, and thank you for submitting that. So again, what are the most important things that EHR vendors can be doing to address all these different challenges that were mentioned today?
Yeah,
I'm going to start. Listen to your users.
Yeah.
Go ahead, Matt.
Yeah, I mean, the one thing that I'd love help with, again, I'm like very questionnaire oriented right now with everything. Allowing the patient portal to have a much easier, nicer, patient-friendly, family-friendly way of answering, 25 to 50 questions at a time. Making a much more pleasant experience, I think would help everybody. There's just, we know that the longer the questionnaires are, the less likely they're going to be answered. And then the more difficult it is for the families to answer the questions or make corrections on them, the less likely they're going to fill that stuff out with. And we're probably never going to get those answers in clinic.
I can go next. Definitely agree with that in terms of portal access with Matt, trying to allow for multiple languages and ease of use. I would say that regarding the confidentiality piece is really top of mind for me. And I think if EHRs could make the sort of data components more granular in terms of whether it could be hidden or not hidden, that would really help us a lot. We're trying to think about, do we have to just axe the whole med list, for example, if we're trying to hide one medication, but if we could have it granular at the level where I'm hiding the Suboxone or naloxone or whatnot, that'd be a lot easier to have that configurability. And in addition, just like, as Matt said, EHRs are not primarily set up for pediatrics, but I think like just having baseline foundation, vital signs that make sense per age, et cetera, would be really helpful.
I would just add that I think a lot of EHRs are building more and more customization ability in, which is great. But having, like Mark said, those foundations where you can just plug and play, and these will fit into the limitations of taking care of pediatric patients, which is very different from adult care, would be really helpful. So we don't have to sit down for weeks on end trying to come up with our own customization of these settings. The EHR vendor would be so helpful if they've already thought through these and kind of present a solution that aligns, which depends on, standardization. As I said, it's not, a lot of these things aren't standardized across the country. We don't have recommendations from our academic organizations to give guidance to what's the best practice.
Great. Okay. Next question. Can you please share some examples of how pediatric data is lost during system migration or any new system implementation?
Sarah and I probably have a fair amount of experience in this as we've transitioned from one EHR vendor to another recently, but it really depends on the mapping. So in your old EHR, if you've mapped certain data to different locations in a database, it's really, really important that you keep those relationships consistent when you map it to the new database, because if you don't, all that data is going to be lost. Certainly, you can try to archive as best you can and seek the data in the archives, but most providers, if it's not in front of them, won't bother to go and look. So I think that's one example I've seen of the data being lost.
Yeah, I can give one specific data example from our recent transition as a growth chart. That is not a typical data type necessarily. And so growth charts are hard to bring from one system to an old system, bring to the archive system. Not something that we look at in adults, the growth chart, what is that? But in pediatrics, especially primary care, even subspecialty care, I think we open that for the majority of the patients, looking at their weight and height changes over time.
This mapping that's done, is that typically manual, or can it be automated, or does it depend, I guess, on the EHR system?
It depends. There certainly are vendors that will help you map. And certainly if you're making a transition to a new system that has been done before, I think there are a lot of sort of guide rails, but in the end, it's going to take a human eye to look at it and see if it makes sense. A lot of testing.
Gotcha. All right.
And I will just say it's even worse when it's the second data conversion. People that I see on their third and fourth iteration of an EHR, it looks like there's 4 different languages, and remember, there is no standard database storage module or standard in EHR. So database tables are totally different from one thing to another. And early on, ugly data, and when you have new standards, what do you do with the old data that didn't meet the standards, right? Like there were the first iteration of EHRs, vaccines were not in CDX codes, they were just words. What do you do with that when you have old data? And our kids are gonna now be the first generation that has completely electronic, but whispered down the lane, maybe morphed over several data conversions and exchanged among several different vendors. It's gonna be interesting.
Right. And the second part to this question is, how do pediatric patients that are in the system, for example, foster care, feature into the health data collection, consent, and sharing dilemma?
I'll take first crack, but this really feeds into that question of maybe what Sonia was asking about, how EHRs could improve, but EHRs aren't built to really capture the nuances of who we need to ask for permission, because someone who is in foster care, maybe they're reunited with their biologic parents later, and so that access keeps changing. It can be very fluid at times, and so I think building in systems that allow for the nuances, the granularity of who is the guardian or has permission to consent right now, and maybe there's a timeout after X number days or weeks or whatnot, I think just ultimately ends up being more human effort. I think just trying to verify and check that you are who you say you are and you do have permission to grant consent, et cetera. Those are areas that are just sort of just work that people have to do. We need people to actually ask those questions. If EHRs can take on some of that, that would be pretty fantastic. But it's just, we can get the data correct. It just is going to take more effort.
Great. All right. So I have questions from Rita to the specific doctors. So Dr. Kressly and Dr. Stewart, this question is for you. How well are EHRs supporting proxy access / controls for adolescent or other individuals?
So it's all over the map. There's some, and remember that not all EHRs have their own portals. Some people use standalone portal companies. And also then it depends on how it interacts with your EHR. So if a portal has the ability to separate a proxy from the patient themselves, or 2 different parents, maybe not in the same household for the patient, it may not be able to get reabsorbed back into the EHR in a way that makes messaging sort of seamlessly supported. So it is really all over the place.
Yeah, that's what I was gonna say. It's so dependent on your EHR and your vendor. Some have great options for customization, and some, like Sue said, have very limited or not even the option at all, and you have to go with another product.
And some organizations have the capability but haven't explored it, and because they're frightened. And there are still a lot of, even with 21st century cures, there are still health organizations across the country that are just turning off all portal access for kids 13 to 18. They're just not playing. And that is a health equity issue.
Great. All right, Dr. Fradkin, this question is for you. What social needs information is reflected in the patient's charts, and are any collected directly from patients? For example, I'm thinking assessments along with or only conditions or diagnoses.
Yeah, good question. So in terms of where social needs information is reflected in the chart, for our EMR, there is a social determinants of health section that shows up in sort of the main part of the chart when you open it up, as well as sort of visit-oriented healthcare maintenance. But again, this is not a pediatric focused chart, and for instance, I think the social determinants of health that always pop up no matter what age the child is you know, you can have a 5-year-old and they're asking for tobacco use or vaping, think alcohol use, depression, stress, physical activity, social connections, intimate partner violence. I think there's a financial resource strain one on there, food insecurity, housing insecurity, utilities, assistance, and transportation needs. And again, we ask some of these questions on some of these screeners, like the hunger screen for food insecurity and things like that. But this sort of goes with what I was talking about before, like where should this information come from, and you know, medical, legal, HIPAA compliance. Should we be able to just, you know, get this information automatically from the parents' chart if they're in the same healthcare system and they're living in the same household? Do we need permissions for that? Should we get permissions for that, and how do we get it? Or should we be asking this more directly for during the patient visits? In terms of assessments along with other conditions, we do have assessments that have to do with diagnosis specific things that will then alter the patient chart and their healthcare maintenance section to make sure we're doing, you know, evidence-based care medicine or practicing with newest guidelines, such as if we designate a child with asthma or a certain type of asthma, mild, intermittent, whatever, the chart is smart enough that it'll know if they're on the recommended medications. Are we following up with them initially, which will then also lead to questions for if there's tobacco use in the home and things like that, which then touch on social determinants of health. But I would love our EMR to, or basically have the well visits look more like, I don't know if people are familiar with the Compass Rose that Epic has, where social workers or sort of are able to use to sort of really address these things, and with really current resources in the community. It'd be amazing if we could have something similar like that in the pediatric part of the chart.
Great.
I want to just say
ahead.
one thing, Joanna.
Yes.
Interesting story about social determinants and after visit summaries for those of you to think about. There is now a reported case, and this was brought to my attention by our president-elect of the AP, Sandy Chung, where a mother reported housing and food insecurity on her social driver screener. She was the primary custodial parent. The father saw that and sued for permanent custody of the child, and the mother lost the custody of the child because she reported having social difficulties. So again, this goes to sensitive information and who has access in messy families.
Thank you. And last question is for Dr. Lowe. What technical concerns do you see with digital health modalities that need to be addressed other than broad pen and privacy to better serve pediatric needs?
I am interpreting technology concerns, and I guess the overall view is that just remembering that it's not one size fits all. And so a lot of technology and digital health apps and whatnot are often focused on the adult, and just assuming, contrary to what Sue had put in her first slide, that pediatric or children are not just small or little adults, but like really trying to keep in mind that their physiology is different, their their digital health data is going to be different. And I think just really taking that into mind, a heart rate of 100 might be normal in a certain age of child versus very unusual for an adult, for example, in a certain scenario. So just really taking into account to design for the pediatric patients, that would be the main thing. And honestly, when it comes to permissions and whatnot, speaking even as a parent, I think trying to navigate this whole area is very challenging. Just recently, we made the big step of trying to connect one of my kids, and so not with a phone but with a watch, and then that led to all sorts of different questions and issues as well. Do you turn it off during school? Things like that. And so I think we're all trying to feel our way through this permissions and privacy kind of morass, but the conversation is definitely needed in terms of furthering it.
Great. Are there any other questions from our participants? We have 4 minutes left. First of all, before I go to the next slide, I just really wanted to thank, on behalf of the Washington board, to our speakers, Dr. Lowe, Dr. Fradkin, Dr. Stewart, and Dr. Kressly. You guys have done an amazing job of presenting not only your passion for healthcare IT, but you really educated us on some of the top challenges that I myself was not aware of. I recognize that it took a lot of time to present and also prepare for this. So thank you for taking your personal time. It looks like there's no more questions. So I just wanted to share with everyone our coming events. The next one is next Thursday, and that's going to be our Nurses in the Innovation Space. So we have 4 great nurses that have background in nursing that have moved on into the healthcare IT space and innovative roles. That's happening next Thursday again at 4 o'clock PST. Then we have another one that's being hosted by our Student Engagement Committee. So our chapter has a few committees, one of them being Women in Health IT, Cybersecurity, and then this one, Student Engagement Committee. They have an event on August 10th at 6:30 in terms of roles and data. So a lot of our students that are members are always questioning, what kind of career can I have in healthcare IT? How do I get there? So they're doing a series of different roles in health IT, and this one specifically on data roles. And then our first in-person networking event since the lockdown, basically, so since 2 years, that's coming up on August 17th, and it's going to be in the Soto Urban Works area in a winery. So if you're interested, just keep an eye on the newsletters. You can also register online through our site. And again, thank you all for participating. If you have any questions, visit our site, post a question in there. Looking at the chat, no more questions, but thank you again for your time. Again, this is recorded, so we'll post it up on our YouTube channel. Thank you.